Thank you, Bridge. And actually, talking about preparedness to pandemics, the COVID-19, I think, showed very clearly the role of public health services in that preparedness. So I was thinking it would be interesting to zoom out from, engagement at a community level to see a bit also the larger contextual policy frame, and in particular the role of EU in healthcare. And I will base that on some of the findings of a project I've been working in with Roland Dern and a whole team since in the last 5 years, called Labor Politics and the EU's New Economic Governance Regime. Oh my God, nobody understands anything. So labor regime is basically the employment conditions of workers, but also their conditions for what is called in social sciences social reproduction, yeah, including public services. So where do I? So we look at these two areas, and in terms of public services, we look at three sectors: water, transports, and healthcare. And this is where I came in. I'll talk about the EU's new economic governance regime and its role in healthcare. But I think one of the finding of the project in this area is to address what could be called a myth of political rhetoric at both EU and national level. Healthcare is a national competence, yeah? According to the principle of subsidiarity that was introduced in 1993 in the Maastricht Treaty, and it was translated in the public health title that was introduced at that time, which became nowadays with the last treaty, which was in 2007, Lisbon, in the Treaty for the Functioning of the European Union, Article 168. And it says that the EU should respect member states' responsibilities in the area of the organization of healthcare. So basically, what is repeated, by national governments, but also by the EU when it fits it, is that EU has no competencies in healthcare. Am I okay? Oh, okay. The question that we would like to pose is it really so? And first we looked, so we would argue that EU matters for health services because it had already intervened in healthcare based on what we could call both the nominal competencies and what we would call the actual competencies in healthcare. And this is what it would look like. So the nominal competencies would be here, this public health title introduced in, that I already mentioned, introduced in the Maastricht Treaty. But we also have a spillover from other areas of competence of the EU that we would call actual competencies since the 90s, yeah? So first we have the European Monetary Union and accession processes that were based on a certain a number of convergence criteria, yeah, fiscal discipline, both in the old and the new Eastern European member states, that placed indirect fiscal constraints and pressures on payroll taxes, and that put a concrete pressure on healthcare. Why? Because healthcare in all countries, EU member states, is an important public expenditure item, yeah, around, I think, 16% EU average. So that translated in member state adopting what we call commodifying healthcare reform. What does that mean? Commodity means something that can be sold and bought on the market. So bringing healthcare closer to that, yeah? Then in the 90s, we also had the process of the we also have the increasing application in the 1990s and 2000s of EU internal market and competition law. These are different articles in the treaties. Yeah, in the area of state aid and procurement legislation, but also, if you know, the main directive in healthcare is the 2011 cross-border healthcare. And all these measures opened healthcare to commodifying healthcare reforms. And finally, this is where we jumped in. We looked more closely at this new economic governance, which was set up after the financial crisis. And as we will see, it included direct country-specific policy prescriptions in healthcare. So let's see what is this new economic governance. I won't go through all this, but just to say it's a whole annual cycle of macroeconomic policy coordination. What does that mean, macroeconomic policy coordination? Is about reining in the deficits, yeah, and the imbalances that may lead to a crisis. Yeah. How did it start? It started after the financial crisis, when a series of countries, both inside and outside the Eurozone, for example, Ireland or Romania, were submitted to bailout programs. Yeah. Then, after the 2010 Euro crisis, the EU set up the European semester. So institutionalized what came first as an emergency measure, the bailout programs. And this is where we are at, the European semester. And what is new compared to what was there before is that now we have a series of sanctioning procedures that legally underpin some of these country-specific recommendations for each member state, and which we consider they are hard, yeah, because there is the threat of sanctions. In the case of this excessive deficit procedure, it existed before, but now we have this, fines 0.2% of GDP. In the case of this new procedure introduced in 2011, up to 0.1 GDP. So that's the EU's new economic governance regime. And should we care in healthcare? Yes, because of the importance of public healthcare expenditure in state public expenditure. It was hit, and it was hit with many times here these two legal bases for the country-specific recommendations that included healthcare in their text. So what we did in the project was to look at these policy prescriptions in healthcare for 4 countries, Germany, Italy, Ireland, and Romania, between 2009 and 2019. We started our project before COVID, but also COVID, as I will briefly explain, changed a few things. Yeah. So what we did was to look for these policy prescriptions in these documents, the MOUs, Memorandums of Understanding for bailout programs, but also the country-specific recommendations issued for each country under the semester. And we classified them along 3 dimensions: resources for public health services, the organization of public health services, and access to public health services. Yeah. So depending on which area they address, so that we can more easily talk about them. But also, we classified them on whether, according to whether they have a potential to decommodify health services, meaning to bring them closer to public, redistributive, solidaristic health services, which are very important for social inclusion, but also for responses to pandemics, for example, or whether they go into the other direction, bringing them closer to a market, a commodity. Yeah. So what we see from here, yeah, general look, is much more prescriptions are in this commodifying, yeah, and they include then decommodifying. They include in the area of resources quite a few to reduce funding and expenditure, but also service levels. In the area of organization, they include prescriptions to what we call managerialize, meaning adopting management, which comes from private business, as a model to run public services, or to liberalize services, meaning opening them to private actors. And finally, in the area access, we saw measures that sought to increase the cost for users and to reduce service coverage for users. I won't go into that. That's just to see how we tried to capture the mapping of these different prescriptions of the commodifying prescriptions in healthcare for the 4 countries over the period under study. And you see we put here Germany, Italy, Ireland, Romania, and then the years, yeah? And then we also classify them according to their strength. So if they have a backing, a stronger legal backing in these sanctioning procedures, yeah? You remember we talked about the excessive deficit and the excessive macroeconomic imbalances. So if they are legally backed by that, they are stronger. It's a whole discussion also for countries that are in the procedures, yeah? So we see, look at here. So we see that 2009, 2013, we have quite strong prescriptions, commodifying prescriptions. And what did the national governments do? Mostly they adopted these measures, yeah? And then we see a lightening, yeah, as the crisis winds off, yeah? We could talk the whole day about this, but I won't. Just to give you an idea. Now,
sorry, is it visually representative? Were there way more prescriptions for Romania and Ireland than there were for Germany and Italy?
What do you mean representative?
So just looking at the size of the number of symbols in
yes.
relation to the country, are you saying that for Romania there were vastly more? I'm just wondering.
Yeah, so we mapped what we found in the documents.
Germany, which has like
yes, yeah.
Okay.
But that's another very interesting story, you know, and question, why do you have much more here?
Yeah.
And the answer that we give is that actually Germany and Italy had already commodified their healthcare services during the 1990s and 2000s. So that's why they were not targeted, yeah? They had the DRG, maybe you know about that. Ireland was asked to introduce it, yeah. And then what we see over this period is a quite important increase in the proportion, in the rate or share of private healthcare hospitals and healthcare hospital beds, private hospital beds in these 2 countries and especially in Romania. So pushing the 2 peripheral, countries in Europe, Ireland, towards more commodified healthcare. So our conclusion, given that type of reasoning that I just explained, is that we have a common script of NEC prescriptions in healthcare, the new economic governance, that curtail resources for public health services and increase the marketization of their organization, which amounts at a true agenda of commodification of healthcare. So that was just up to 2019. What happened, after COVID, it's a long story, but I think the most relevant thing, one of the most relevant thing about apart from the suspension of the Stability and Growth Pact, which underpins one of the sanctioning procedures that I talked about, which allowed for huge increases in healthcare expenditure, both at EU level and national level. We are still there. They are still debating now. We are having the energy crisis. It's not yet the moment to reinstate it. But we also had in 2021 the adoption of the regulation on the Resilience and Recovery Fund. So a huge pot of money made available at EU level, either in grants or in loans, for a period of up to 2026. And that leads to the introduction of an additional bureaucratic exercise, that was brought into the semester, which are the national resilience and recovery plans, Probably you know something about Ireland's. Yeah. So I think all countries have adopted, finally adopted one of those. And actually, they have been elaborated in close collaboration with the European Commission. So the European Commission increased its involvement in the elaboration of these national plans. These national plans are including a series of reforms that have targets and milestones, and the funding is conditional of having an A in each of the four areas. Yeah, the Green Agenda, digital transition, the country-specific recommendations from 2019 and 2020, and the EU pillar of social rights. And I just identified that 3 of them are are talking very importantly about healthcare. So there is a big question, that's another, the future research. Where are these national resilience and recovery plans will bring healthcare? In what direction? There is a lot more money for infrastructure on the one hand, but is more money for more resources for health services? Will they be used in a solidaristic, redistributive, public approach, or will they be used, as they could be very well, to bring in more private actors into into health services? So just to finish, I would like to point you to an article that I published with Roland last year, where we talk of this idea of a European healthcare system. Basically, it's not that they are dictating everything, but a system in as much as health services, national health services, are linked across border in the larger whole. And that's a reality of how healthcare is in Europe today. We saw 2 elements, the EU laws and this new economic governance regime, as well as we touched a bit on processes of healthcare commodification, but we didn't talk about intra-European healthcare worker and patient mobility. That's for another time. So thank you very much. We are just bringing over the line, hopefully very soon, the book on the whole thing with Cambridge University Press. Thanks.